I want to talk a little bit about general considerations when we deal with Parkinson's. And the first is, not always obvious to everybody, is to establish the diagnosis. So there are a lot of things that cause Parkinsonism, and they're not all Parkinson's disease. And that has a lot of implications on how you manage the patient and the prognosis. So I'll talk a little bit about that in a minute. As I mentioned a second ago, age is incredibly important. Young onset patients have different problems than older onset, more typical patients. They are managed differently and have a different prognosis. When we're treating people, not only do we care about the diagnosis and the age, but we want to know the disability. And the level of disability depends on what symptoms they're having and the severity of symptoms, in addition to the patient's background. So if you have somebody who is an artist, a little bit of tremor can be incredibly disabling to that person. But if you have somebody who's retired and doesn't have to do a lot of fine motor movements, they may not be disabling and defer treatment for that. So the level of disability for that person is very important in dictating what we do. All right, so when we talk about Parkinsonism, we're talking about really a bunch of symptoms, and it's really more of a syndrome, and then there are diseases associated that can cause those symptoms. So a rest tremor, for example, is Parkinsonism, where an action tremor is not. Stiffness, slow movement, lack of movement, mass face that you see people with Parkinson's often have, stoop posture, micrographia, and later in the disease, postural instability, so poor balance. Now, not everybody has these, especially early on, and it's not inevitable that they'll all get it, just like any disease, but it's a constellation of these symptoms that we use to make the diagnosis. And again, usually early on in young people, just like the patient that was presented this morning, back pain was a problem, and I think she actually had a surgery, if I remember correctly. Many people do. I can't tell you how many young people, if they don't present with tremor, they end up with a surgery, either shoulder, back, before they come to us. So making the diagnosis, again, is really important. So the things, I don't have time because we only have a short amount of time. I don't want to talk much about it. Just wanted to present a short list of what can present with Parkinsonism that is often confused with Parkinson's disease. And there are neurodegenerative processes like multiple system atrophy, frontal temporal dementias, which include PSP and cortical basilar degeneration, diffuse Lewy body disease, the list goes on. Those are the primary degenerative disorders that can cause it. But there are other things that can cause it that are structural, or we call secondary, such as small vessel vascular disease is actually a fairly common cause of Parkinsonism. Very different implications, different treatments. NPH is often confused, but shouldn't be, of course. And then medication. So we see drug-induced or medication-induced Parkinsonism all the time. Saw 2 patients yesterday at the VA for Parkinson's disease, and in fact they had medication-induced Parkinsonism. Indistinguishable. Okay, so rule of thumb to try to remember, you'll be right most of the time if you remember these few rules. If they have an asymmetric onset, they're dopa responsive, and they have a rest tremor, and they don't have early falls or what we call atypical features such as cerebellar signs, long tract signs, early dysautonomia, they very likely will have Parkinson's disease. Now, it doesn't mean that everybody's going to present that way, but if they have those things, you're probably right. You're going to be, most of the time, about 90% of the time, predict the pathology. Okay, so this is a patient some many years ago here who had all the classic features. So this is off, and when we talk about off, we mean we hold their medication for about at least 12 hours. So they're very different. You can see he's asymmetric. He's got a rest tremor, more on the left than on the right. He's slow. This is real time. He's got a masked face and has problems standing. He's stooped over and very slow. So this is kind of a classic. He's had this for quite some time. He was another young onset patient. See how when he walks, he shakes. If almost anybody who walks when they shake like that has got Parkinson's disease. It's a very specific sign, so it's a good thing to remember. Almost always. All right. So now I'm just going to talk about Parkinson's disease and not talk about the other disorders because it's so common. You know, they estimate maybe 500,000, 1 million people in the U.S. have Parkinson's. Get a higher incidence with age, so more people are getting older, we're having more disease. Lifetime risk is somewhere less than 1 in 100 for most men, though women get it a little bit less. Most people get it around early 60s is the mean age, but there's about 15% that'll get it under the age of 50. It's still a lot of people. It's like 100,000 people, so it's actually still relatively common in the young. It's still, you know, even though it only makes a small proportion of the total population, but it's a significant population. And for this group, they usually become the best surgical candidates. All right, so just want to review the medications and point out a few things. One is, you know, most of our medications are really, actually all our treatments are really geared towards improving dopaminergic transmission. And, you know, even though that dopamine is the limiting factor for the motor movements, it's really much more of a diffuse disease in the nervous system. There's problems with serotonin, so they have sleep problems. They have REM sleep behavior, constipation, there are Lewy bodies in their GI tracts. It's in the cortex, so they can get some cognitive problems. It's not just a dopamine disease, but what works the best, it's the best treatment we have, and it does in early disease especially work quite well. So it's really what we talk about a lot, but we really need better treatments for other symptoms. So we have levodopa shown in the cartoon of the presynaptic neuron on side. It's a precursor. Tyrosine hydroxylase is the rate-limiting enzyme in dopaminergic neurons, and there's not enough of them there because many of the neurons are dying. So you go upstream, downstream of that, and you give them levodopa, converts it to dopamine by a decarboxylase, and you increase transmission that way. Carbidopa prevents peripheral conversion so that you don't get the side effects, and you need enough of it to prevent the side effects so you don't get dopamine outside the brain. And then the other major class are called dopamine agonists. It's shown there in the circle on the bottom. We have 4 retigatines on hold right now. It's a patch form, but they're synthetic forms, and I'll talk in a second about the pros and cons of those. But basically, those are our mainstay, the agonists and levodopa preparations. This also means that you don't want to do the opposite, right? So on your check sheet in your orders, whenever you have a Parkinson's patient, don't check that box to give them antiemetics because you're going to make them worse, or an antipsychotic. Don't call in when they're sundowning some droperidol or Haldol or whatever because you could kill them. So there's those automatic check boxes are the worst thing you can do for a Parkinson's patient. All right, so these are the guidelines. I'm not going to kind of go over this in detail. I just put it up there because there's a lot of consider this and consider that, and so it really needs to be individualized. There's still, if people are, we do like to emphasize, shown on the right side of the slide, the non-pharmacologic aspects. Exercise really helps these people in the short and the long run, so we really try to promote that. We try to educate people to know that life's not over, and many people, and in fact the majority of people, live very long and high-quality life despite having Parkinson's. But we do have pharmacologic therapy, and that's, you know, what we do. So obviously the best thing would be to slow or stop the progression of the disease, and unfortunately we have nothing convincingly does that, although the MAO-B inhibitors might make a little dent in modifying the disease. But we really are dealing with symptomatic therapies, and like I mentioned a second ago, levodopa and dopamine agonists are our mainstay. So the MAO-B, there's a long story of how we found MAO-B inhibitors, and the story is interesting and I don't have time, but it probably was wrong, but they may work anyway to some degree. Now we have two of them, selegiline and rasagiline. Selegiline is the older drug. That actually gets converted to amphetamine, and that's why the patient that was presented this morning got jumpy and anxious. Is sometimes you get that amphetamine effect, and it has more side effects than rasagiline, which is the newer compound that goes by Azilect. Doesn't get metabolized. They both have a very small symptomatic effect. So most patients will say they don't feel a difference, but some patients will say they're a little bit better. And if you do a big trial, which they did with these drugs, you always get a little confounded by that symptomatic effect. If you do enough people, you will measure a few points on our rating scales just to confuse the studies. There's big studies for these, Datatop for selegiline and Adagio, which I'll show you in a second, which is kind of those are the kind of landmark studies in our field, and they suggest that they might modify disease progression. One other aspect, rasagiline and can help make levodopa last longer. As the patient this morning had to take the pills every 2 hours, that's because it would lose its benefit. It's called wearing off. So we really try to do a lot of things to try to improve the kinetics, and rasagiline in particular can help wearing off. There's a sublingual selegiline, probably doesn't work, might, and PO selegiline doesn't appear to work. So this is a study that if anybody has the time wants to read, it was in the New England Journal just about 6 months ago, 8 months ago. And basically what they did was they started de novo patients, so people before they're on any medications, either on rasagiline or placebo. And then after about 8 months, the placebo group was switched to rasagiline, followed another 8 months and see who was better off. So if it was neuroprotective or disease modifying, the people on rasagiline that were on it for 16 months should be better off than the people only on it for 8 months. But it does address the symptomatic effect because they're both on the drug for the last 8 months. And if you look at the top graph, you can see that the curves never cross. And that suggests that at extra 8 months of disease modification was beneficial. So that's at 1 milligram. Unfortunately, 2 milligrams, which there's no reason to think it should be any worse and maybe better, didn't do it. So it's still a huge controversy in the field, but 1 milligram is what we use with the hope that that is a real effect. Now, this is a huge study, over 1,000 people, the biggest study in Parkinson's ever done. So the statistics are very robust. So I can't explain it, and nobody really can, and they have some hand-waving in the article, but it doesn't really make sense when you take them to town. So we don't know. Maybe it's disease modifying. The FDA wasn't convinced and hasn't given that designation, though it is approved for early disease because of symptomatic effects. Okay. So the meat of what we do really is levodopa, and that, you know, it's been used for almost 40 years now, and it's still probably one of the best drugs in neurology, let alone Parkinson's disease. And it's the most efficacious drug to treat Parkinson's symptoms, the stiffness, the slowness, often tremor. All the dopamine responsive symptoms are treated best by levodopa. Improves our rating scale by about 50%. And I give you that number just to give you some relative numbers compared to other drugs. For example, rasagiline, maybe 2 to 5% max. Levodopa has a very short half-life, and without other medications like catechol-methyltransferase inhibitors like Comtan, the half-life is about 90 minutes in the serum. So very short half-life. The controlled release, slightly longer. With entacapone or Comtan, it's about twice that, 180 minutes. Still a very short serum half-life, one of our biggest problems. And there's a significant problem with protein interaction. So Levodopa is a neutral amino acid. It gets absorbed through the transporter in the gut, and so if you give it in the environment of lots of other neutral amino acids, you don't absorb it very well, and therefore it doesn't work. So the timing of the medications is very important. So whenever you write the prescription for levodopa, you need to keep meals in mind. Usually we like to give it 45 minutes to an hour before a meal. That way you don't have the protein effect. If you give tube feedings, this is the thing, I'll get this all the time. I put them on their regular dose, but they give them continuous tube feedings. It's almost like not giving it to them. The blood levels are barely detectable. So it's a huge effect. It's not a small effect, and I'll show you a slide in a minute. There are side effects with every medication. The levodopa has the fewest, at least in the short run. It can cause nausea, vomiting, things like that, which are usually easy to deal with by how you start the drug. The main problem is the long-term risk, which are motor fluctuations, which are good for you guys but bad for the patient, because that's what we operate on. Okay, so one study I wanted to show you was that to demonstrate that levodopa does not make the disease progress faster. So there's a few things that get spread out there about levodopa. One is it makes the disease progress faster, and this is the early versus late levodopa study, or the L-DOPA trial that was in the New England Journal. And just in a nutshell, people were started on either placebo or 3 different doses of levodopa, and then they were taken off of it for 2 weeks. And they wanted to see if you were on 600 milligrams of levodopa, after about a little less than a year, you're taken off the drug, you should be worse off if it makes the disease progress faster. And in fact, they saw the opposite. So clinically, it seems to maybe even slow the disease down. There's some imaging data that confuses this story, but clinically, there's no doubt it does not make the disease progress faster. And it never stops working. So those are the 2 things that people hear about it over and over again. So I always like to stress that. And it's well studied now. Okay, so the protein effect. This slide is from 1972. But I'd like to show it because people forget this. And neurologists forget it all the time. So the one in black is when you give a levodopa with water. And the one in white is when you give it with milk. You can see the blood levels are quite different. And so these are what we call dose failures. People take their pill and it doesn't work. And this is the #1 reason for dose failures, is taking the medications with protein in the stomach. Okay. So dopamine agonists, they're the other big class of drugs. And you hear about them a lot because levodopa is generic and the dopamine agonists are all heavily marketed. And in fact, the marketing is so big here in the U.S. that we use it so much more than they do in Europe, where it's not marketed quite as heavily. A lot of controversy on when to use it, how to use it, versus levodopa. So I'll kind of review briefly the pros and the cons. So the pros are that it has a very long half-life. These are chemicals that are made so that they stay in the blood, and there's a whole bunch of different half-lives. We even have 24-hour formulations now. So they can be absorbed without the protein effect. You can give it through patches, injections, because these, again, are chemicals that we can alter their chemical characteristics. The big advantage is that they delay the onset or reduce the chance of getting fluctuations when you start with an agonist. And it's a large effect. The downfall of these is that and it doesn't work quite as well. So if you get 50 points from levodopa, you get about 30 points from the dopamine agonists. So not quite as efficacious. And the side effects are much worse. So sedation is very common. We have to ramp it up very slowly over weeks and months. Nausea is a problem. Hallucinations are a problem, but probably the biggest one that we have that really plagues us now are behavioral changes. So these are the people that have compulsions. They gamble, sexual compulsions, you name it, eating, internet, I mean, and they're bad. These destroy people's lives. The worst side effects. Bob, are you on Miravax here? Anyway, so they are bad. And I could tell you lots of stories that are very humorous to tell about, you know, bondage in 80-year-olds or, you know, cocaine. I have an 85-year-old that shoots cocaine with hookers. And it's all started after they take these drugs. They are humorous to us, but they're actually completely can destroy people's lives, and it is the most serious side effect of any medication that we deal with. So you really got to ask for it. It's actually become one of the primary reasons that a number of people go to surgery now is they get taken off the agonist because of these behaviors. They get really bad motor fluctuations and end up needing surgery. So it is a big problem. The estimates are about 15% of people with the agonist get it. If they're at therapeutic dose, most of us believe it's closer to 50% to some degree. It's dose dependent. There are tolerable ones. I have a little old lady that has compulsions for bingo, and she's at a nursing home. She loves her bingo. It's once a week. She can only lose $1. It's okay. We don't mind that one. And she doesn't mind. So, but you really it's really quite amazing, the compulsions that people have. Only happen with the agonist, or primarily with the agonist. Okay, so what we worry about is this. So this is the same gentleman 15 minutes after taking his medication. Timing is critical in these drugs. So those are dyskinesias. He would much rather be like this than he was before. Patients always prefer it. In fact, spouses and partners complain about dyskinesias. Patients complain about being off. They don't mind being this way. They're often not even aware of it. But he moves faster. He's much more comfortable, and he's much more functional this way.
This is after an agonist or after?
This is after levodopa. Now, agonists can make, once you have fluctuations, an agonist can make them worse. So you can see when they're walking, he could have Huntington's disease. You'd never know the difference. Here's some of the data that mention about how they delay the onset of fluctuations. So if you look at the right graphs, look at the top. That's probably the easiest. People were either started on levodopa or an agonist in a blinded manner. In this case, it's ropinirole. Same with every agonist that's been done. And when do they get fluctuations on the side? So there's a survival curve. So the red on the top shows that basically nobody gets fluctuations if you stay on ropinirole monotherapy, but after 5 years, about half the people do with levodopa. The one underneath it, the red line, is some of the people, in fact, many of the people needed levodopa because it just didn't work well enough. In fact, the majority will after about 2 or 3 years. But even then, when you start levodopa on top of the agonist in combination, shown in the red, only about 15 to 20% will get it at 5 years versus about 60% in the levodopa group who needed extra levodopa on top. So it can delay the fluctuations, and this is what we're dealing with. Now, shown on the left is just some primate data to show that it predicted this effect. So the real issue is, when do you start an agonist and when do you start levodopa? Well, the obvious answer is, when are the risks of motor fluctuations the worst? And that's in the young patients. They tend to tolerate these side effects better as well. So we tend to start patients that are younger on agonists just for this reason. And that's really the only reason. Older people really have problems with the agonists. They really don't tolerate them very well. But the risk of fluctuations are actually much, much lower. So you don't worry about levodopa as much in the older people. So why do people develop it? And this is just a small cartoon to demonstrate a little bit about what the kinetics are. So in the gray line there, that's kind of supposed to show levodopa with a very short half-life. Rapidly absorb, blood levels go up quickly, but come down quickly, and then you take another dose, shown by the arrows, and it goes up. So you get this, what we call pulsatile stimulation. And if you do recordings in the OR, if you do in primates, you'll see that there's a tonic release of dopamine in the normal state. And so what we're trying to do when we treat patients is get more like that red line, which we call tonic stimulation. So whether it's with a long-acting agonist where the blood levels are stable, or by giving smaller frequent doses of levodopa, along with drugs like Comtan to make it last longer, we can get closer to that red line. So it's this concept of tonic versus pulsatile stimulation. Before they develop it, this takes years to develop, so it's almost, for those epilepsy people, it's like kindling. You know, we think it kindles the brain over years, and once you get these, you're kindled and it stays. So even if you get rid of the fluctuations, I can give them at 1 or 2 doses of levodopa once they develop, even years after being stimulated, and they will still develop it. So it changes brain plasticity. Okay, so in initiating therapy, the simple algorithm that we use is basically shown here. If they're not disabled by symptoms, you don't necessarily need to treat. You tell them to exercise and all that stuff. Many people believe that, that starting an MAOB inhibitor is a good thing in those people. I tend to do it. I would probably do it myself, just in case it slows the disease progression down, but it's not completely accepted. I put an agonist there, and I forgot to take it off. There was finally a study done, exactly the same study. It hasn't been published yet, where they did delayed start, like the Adagio study with rasagiline, and it was actually negative, so that I think nobody would start an agonist now unless they think the symptoms are disabling. But an MAOB inhibitor is still on the table, and I would say a large number of people would do it. The evidence for rasagiline over selegiline is not great. It's a little more convenient, may have fewer side effects, but it's a lot more expensive. So you'll see people using both, and it's perfectly appropriate. If they have some disability, most people will start with an MAOB now, unless they're older individuals. Hope that it'll slow the disease progression down, get a little symptomatic benefit with very little downside. In the young, we tend with agonists, and in the older people, I tend to like controlled release Sinemet, but a lot of people like immediate release, and there's some subtle differences. If it doesn't work, you got to think about, is this the right diagnosis? Because like part of the diagnostic criteria is dopa responsiveness. And so we try some other things. Tremor doesn't always respond to dopa therapy, so occasionally, especially in the young, we'll try things like anticholinergics, and that can help the tremor, but it's not well tolerated by many people. So in advancing disease, so the patient this morning did have advanced disease after she was a particularly difficult patient, the symptoms, I mean. Is these motor fluctuations, these ups and downs. Michael J. Fox is the poster child. Takes a pill, goes from off, can turn on, and anybody who's spent some time with him will see that he has some periods when he looks absolutely normal, but then he'll get very dyskinetic, especially when he's speaking in public and when he's anxious. Medicines will wear off, get shaky again, and slow, pop another pill. Classic motor fluctuations. We call it wearing off and dyskinesias. But like I said at the beginning, there are a whole bunch of other things that we call non-motor symptoms, and they're not responsive in general to levodopa, although anxiety is to some degree and depression is, but the dysautonomia, you know, with urinary problems, orthostatic hypotension, swallowing difficulties, postural instability. Like I said at the beginning, people don't get bad problems with postural instability till late in the disease in Parkinson's. So if they're falling early on, it's probably not Parkinson's, it's one of the others. But if you start falling, you know, giving a little tug from behind, they can't catch their balance, that's a late feature, and that's a non-responsive symptom. And then there's the cognitive decline and psychosis, which are actually the things that cause the most disability in patients. So the dyskinesias, this is just a little picture. Usually about 80% of the time, dyskinesias, those extra movements, that choreic-like movement, are when the dose is too high and when the peak is too high. There are about 20%, especially in the young, where as it's coming up, like in the first 10, 15 minutes, they start getting dyskinetic, or as it's wearing off, the last 15 minutes before they're off. They're called diphasics. It's important to recognize that, right? Because if it's the common form, you just lower the dose. If it's the less common form, you actually have to increase the dose or bring it closer together. So it's very, very important to recognize when it occurs. Now, we don't measure blood levels, so we do it by timing of when they take the medicine. About an hour to peak. So the peak dose, if you get the dyskinesias in an hour, their peak dose. If you get it in 5 or 10 minutes, 15 minutes, it's probably more of a diphasic. So the management, you know, we try to minimize the fluctuations. I won't go into the details right now because of time. We can add an agonist if they're not already on one. We can add rasagiline, especially for wearing off. It can make dyskinesias worse, like many of these things. Amantadine is our only drug that actually helps dyskinesias. So we add that on top of it to kind of cover up or suppress the dyskinesias. But if all of those things fail and they're a good surgical candidate, you guys get to see them. So just to remind you, you know, always got to think about non-motor symptoms even before surgery. So there's a higher rate of suicide among patients that undergo ST and DBS. And one of the reasons we think is they have a pre-existing depression that's not treated. So important to improve best you can the non-motor symptoms, and that's our job, but keep it in mind. Okay. So in the last 5 minutes, we want to talk about surgical approaches, but very briefly, and just kind of give you an overview. So people have tried for years to do dopamine replacement or restorative therapy is the modern term for this. This is mostly transplantation. There's now gene therapy as well is being tested. But the other techniques are basically ways of decreasing or improving the balance in that circuit that was shown earlier, and I'll show you in a minute. Either through lesions, and we used to lesion pallidotomy, do pallidotomies and thalamotomies. In fact, the gentleman that I showed you on those videos had pallidotomy many years ago, and now obviously most people get DBS. So basically, transplantation's been around, and it's actually been studied quite well, and we've done a lot of transplantation here over the years. Bob Rand did adrenal transplants here. They didn't work. He actually did some fetal transplants, and they've been done in some double-blinded trials as well with sham surgery. And it turns out that they don't help the group overall. They did help a subpopulation of young, very DOPA-responsive patients, but unfortunately many of them develop what we call runaway dyskinesias. They actually got dyskinesias without taking medication. In fact, almost all of those people have got DBS now to treat the dyskinesias. One interesting thing is actually these transplants are now found to contain Lewy bodies. So it takes 60, 70 years to get the pathological hallmark of Parkinson's disease in the patient's brain. You put in these fetal cells from a non-Parkinson's brain, and within 6, 7 years they actually develop Lewy bodies, which has some really interesting implications in the pathogenesis. And now we start thinking about this disease almost like a prion disease, where synuclein, which is the protein that's misfolded in Parkinson's, can actually be transferred from cell to cell and disrupt and cause misformation of synuclein in non-disease cells. So it's really interesting from pathogenesis story. We participated in retinal pigment epithelial cell transplants. They don't work, nor do porcine mesencephalic transplants. They don't work. So far, transplantation has really been disappointing. Despite that, people are probably going to start doing stem cells just because they make good press, but there's no reason to believe that just sticking stem cells in the brain, making them turn into dopamine cells, are going to help. They're going to need to do more sophisticated things with the stem cells, in my opinion, to make it a useful procedure. It doesn't mean it doesn't have hope, and I think it does, but they're going to need to be regulated or not just simply target dopamine, maybe targeting GABA, which is some of the techniques that people are doing now. Okay, so this is another picture. We all love to show our pictures of circuitry, but surgery is pretty thought of in a fairly simple-minded way. Is that you have the direct and indirect circuit. One of them is hyperactive, which is, if you look at the Parkinsonism in the blue coming from the putamen, that's a hyperactive indirect circuit, and it's hypoactive on the direct circuit because there are D1 receptors and D2 receptors. D1, dopamine receptors type 1, stimulate the cell, and dopamine on D2s inhibit the cell. So they have opposite effects depending on the receptor. So it's a lot easier to cause dysfunction in a hyperactive circuit than it is to improve function in a hypoactive circuit. So that's what we do. We either lesion or put in a stimulator in the GPI or in the STN to decrease the activity of the indirect circuit. It's an oversimplistic statement, but basically it works for this argument. For reasons that aren't completely clear, a lot of tremor goes through the thalamus. So we still target the thalamus for tremor, but that's all it helps, is tremor. Very important, whether it's a Parkinson's tremor, essential tremor, and it can help cerebellar outflow tremors somewhat, but not nearly as effective. So the basics of surgery, that only, except for tremor and dyskinesias, only dopa-responsive symptoms get better. So if a patient is medically intractable and you say, okay, you know, people expect to be cured by this surgery, what I tell them is, you know, you're best on time when your medicine's working the very best and you don't have dyskinesias, that is the best you can hope for. So if you have postural instability when you're best on, you're going to have postural instability with the stimulators. Really important. That's all it treats. So it really just treats motor fluctuations. In reality, it smooths it out. Now that's a huge benefit to patients, but they need to know that those are the symptoms that you're targeting. And that's what surgery does, is target symptoms and nothing more. So if those symptoms are the disabling factor, then you have a very successful surgery if that's what they expect. So selection in patients is really, you know, in many of our minds, 90% of the game. Thalamus only treats tremor. Recent study, which I'll show you, comparing STN and GPI. So I'll tell you about that in a second. But they treat the motor fluctuations, and it doesn't alter disease progression. So that patient that was shown this morning, I still follow her 10 years after DBS. So her postural stability has gotten worse, her freezing's getting worse, because freezing can get worse on as well. So she's getting worse. Her disease is progressing. People do get demented despite the stimulators. So the disease goes on. But if we turn off the stimulators, she's a mess because it's still helping the dopa-responsive symptoms. It always helps that, just like dopa always helps that. Okay, so this is what's new in DBS. We have some new hardware, different stimulators that are more programmable, more friendly. There's a rechargeable form for the people that require a lot of energy. We understand the side effects better with infections and stimulation induced, and we know more about the targets. PPN is being tested, but it's actually, well, let's get rid of that. But it actually has been pretty disappointing. It's supposed to target the gate. So just to summarize some of the recent changes, things that we've learned, is that the benefits are long-lasting. So we now have series out 10 years, and this patient is 10 years. We know the benefits in the dopa-responsive symptoms are long-lasting, but we also know that it doesn't change disease progression. We know better with complications. So what's really helped us is having what I call an independent scorekeeper. So if you keep your own, so the best way it was described to me was you do a lot better when, if you play golf. If you keep your own score, people always do better than if somebody else keeps your score. And that's what we found with complications and benefits of surgery. When people report their own series, their complication rates are always lower and the benefits are always higher. When you do controlled randomized studies, complication rates are higher, benefits are lower. They're still good, but I can tell you that this is both now in the US and in Europe, large series do that. Now, in both large series that were done in the U.S. and in Europe, in the U.S. over 300 patients, six different surgeons, and in the U.K. with about 12 different surgeons, they had an 8 to 9% infection rate. No other papers ever reported anything like that. So that's when you have randomized, controlled trials with study coordinators and people reviewing, overseeing the trial. That's reality. That's got to come down. That's way too high. Hemorrhage rates are actually about what everybody reports, 1 to 2%. Lead fractures really are coming down in frequency and erosions because of improved hardware and I think improved techniques. So infections are probably the #1 problem that we deal with. And everything needs to come out. You really can't treat them with antibiotics the vast majority of the time. You have to take out either part or the entire system. The other thing we've learned a lot about, the neurologist part, is stimulation-induced side effects. And there's a number of them, especially with STN, especially behavioral side effects, hypomania. The patient you saw this morning actually is very kind of pseudobulbar. She'll start crying at the drop of a hat. And this is stimulation-induced. Depression can be associated with this. In fact, in a recent study, SDN depression is actually associated with worsening depression and, as I mentioned, higher suicide. It may be that it's lowering the levodopa because you need to do that, or it may be direct stimulation of that region, specifically the nigra, which has been implicated. We're not sure, but it is associated with it. So you really got to watch for these things. Dysarthria can be a stimulation-induced side effect as well. This is a study that we participated in as well. It just was published in June, so it's worth taking a read. But largest surgical trial in Parkinson's disease ever, and it compared STN versus GPI DBS in, again, over 300 patients. And this is the take-home message from this study, that they're very similar in the benefits. So GPI may favored a little bit in wearing off as well. So they got about 0.9 hours, about an hour more in on time versus STN, but it just missed statistical significance. So by statistics, they're almost identical in motor improvements. STN was associated with a bigger reduction in medication. So if that's a huge issue for a patient, I want to reduce my medication, then STN is somewhat better. If you're, I think we do this surgery personally to treat symptoms, and so we want symptom controls, #1, but that's clearly a benefit for STN, is you have to lower the medications. If you don't, the dyskinesias get really bad. On the other hand, STN was associated with worsening depression. GPI showed better in this study, and there was some executive dysfunction with STN that wasn't present with GPI. And then finally, STN patients had a higher risk of falls than with GPI. So GPI may be coming back. Lots of discussion what people do. STN is by far the preferred target in the world right now. It'll be interesting to see if this study changes people's habits. I personally have a lot of patients undergo GPI because especially the behavioral effects, I think, are a big issue. So I think with that, I can ran a few minutes over, but